First of all, I want to say good morning and welcome you all. And I think it's important just to say I'm thankful. We're thankful. What has happened in the last 3 years is each one of us have survived Waldenstrom's. I assume most of you have had it for 3 years now if you're at this session. So I'm really thankful for that. But maybe more importantly is we've been disrupted for 3 years and we haven't met in person. And it is really nice. I came here last night to get to see people in person again and talk with some degree of comfort. It's been a difficult 3 years, so welcome, and we're really glad to see you. My name is Don Brown. Currently, my wife Mary and I are the support group leaders for the Chicago area, which includes Illinois and Southeast Wisconsin. I was a member of the IWMF Board of Trustees for 6 years. It's hard to remember back now. A lot of the trustees are no longer with us or for whatever reason. So it's nice to come back and see some of those that I've known for quite a few years. Mary and I also, incidentally, in the years that I've had Waldenstrom, have 5 grandkids, which keeps us busy, along with a weekly tennis match or 2 for me, which I consider part of my treatment, by the way. In fact, that's the good treatment. Bendamustine I've had several times, Velcade, and a whole bunch of things. So I enjoy the tennis treatment more than anything. But most important to this group, and the topic of this session, I'm a thriving 21-year survivor of Waldenstrom's macroglobulinemia. And you know, I don't even clap, but I just remember when I was first diagnosed, I didn't think I was going to live to the end of the year. My daughter hadn't graduated from college. Either of my kids were married at the time, and now here I am with 5 grandchildren. So thank you. It's my pleasure to introduce Dr. Prashant Kapoor, a consultant hematologist and an associate professor of medicine and oncology at Mayo Clinic, Rochester, Minnesota. By the way, that's where I go for my second opinions. I don't get there that often, but I do appreciate that clinic. His research is focused in plasma cell disorders, including Waldenstrom's, multiple myeloma, and AL amyloidosis. Dr. Kapoor has authored over 300 scientific papers, editorials, and commentaries that have been published in leading hematology oncology journals, including The Lancet. Many of you may have heard of The Lancet after COVID. That's been one source of a lot of COVID data. The Journal of American Medical Association Oncology, The Lancet Oncology, just to name a few. Dr. Kapoor, welcome to our special education forum, and thank you for joining us.
Thank you, Dan. Thank you, everyone, for being here, and thank you to the IWMF for inviting me for this talk. Many of you who are in the audience today are actually a testament to the progress that has been made in the field, as well as the nature of the disease itself, the disease biology as we call it. So I would like to start off with the definition of Waldenstrom. While there is some controversy, in general at Mayo Clinic, we consider an IgM monoclonal gammopathy with 10% or more bone marrow lymphoplasmacytic infiltrate in the presence of end organ damage, and I would come to that shortly, as Waldenstrom macroglobulinemia. As you can see here in this picture of a bone marrow aspirate, these are the cells that are indeed the culprit. Some of these cells look like small lymphocytes. Some look like plasma cell, which is at the other end of the spectrum. And some cells look like they are somewhat in between and are lymphoplasmacytic or plasmacytoid lymphocytes. So the bone marrow actually has two main components. One is the lymphocytic component, and the other one is the plasmacytic component. And many of the treatments that we are using today are targeting one or the other predominantly, and there are very few that target both. And it is important to identify both sets of these cells in order to reach the diagnosis of Waldenstrom macroglobulinemia, which was first described in 1944 by Dr. Jan Waldenstrom. As you can see here, one of the most important targets is the CD20, a protein that is expressed on the surface of Waldenstrom cells. And the reason I call it important is because we have a drug to target that specific antigen or protein on the surface of the cell. There are many other proteins that are expressed. And as you can see, on your left, it's an alphabet soup, but indeed, many of these are playing a very, very important role in the survival and growth of Waldenstrom cells. And this is a cartoon of a recent publication, which actually Dr. Desa, who's sitting in the front row here in the audience, had invited us to write. And this is a drawing that just tells us the different types of targets that are present. The same lymphoplasmacytic cell that I showed you a picture of earlier. But there are many of these targets that are now so-called druggable targets that we can kind of attack with the treatments that are available and indeed prolong survival. But in terms of the end organ damage that is predominantly seen in Waldenstrom, the fatigue and other constitutional symptoms are predominantly affecting the patients, but there are many other features, some of which are only measured by the laboratory findings, such as low hemoglobin, which may manifest in the form of fatigue, but patients may be completely asymptomatic, or low platelet count, which may manifest in the form of mucocutaneous bleeding, but patients could be asymptomatic. But there are many other symptoms associated with the IgM, which can do a lot of funky things, actually. It can cause, just by increased concentration, it can cause what we call hyperviscosity, or increase the sluggishness of blood flow. That in turn leads to many symptoms, including nosebleeds, headaches, impaired vision, etc. But there are many other debilitating features as well that can be found in patients with Waldenstrom. Not all patients, but some proportion of patients, including something that is known as IgM neuropathy, that is seen in about 1 out of every 5 patients with Waldenstrom, cryoglobulinemia, cold agglutination, etc., as well as I mentioned, constitutional symptoms such as low-grade fever, weight loss, drenching night sweats, etc. About 8 to 10% of patients may have coexisting AL amyloidosis. But about 1 in 4 patients who are diagnosed with Waldenstrom are in the smoldering stage, or so-called precursor stage. In fact, they do not have any end organ damage, so they do not meet the third criteria that I had shown earlier of active Waldenstrom. And so they are labeled as having this precursor condition called smoldering Waldenstrom. The risk of progression to full-blown active disease with symptoms is highest in the first 5 years since the time of the diagnosis of smoldering Waldenstrom, with about 12% per year risk of progressing to full-blown disease. But after the first few years, you can see there is a very slow increase in the risk of progression, and that's a very small risk of progression, and that is very much similar to what we see in patients with IgM-MGUS. So the vast majority of patients, as you can see here, close to 65 to 70% of patients do progress by year 10 of the diagnosis of smoldering Waldenstrom, but there's a subset that will not progress even beyond 10 years, and after 10 years, actually, the rate of progression declines to rates that are very similar to that those observed in patients with IgM-MGUS, that is 1% to 2% per year. What is also important to note in terms of survival is that in a Mayo Clinic study, we found that the survival of patients with smoldering Waldenstrom macroglobulinemia is no different than the age-matched general population. So our job is predominantly to manage those 3 out of 4 patients that are diagnosed with Waldenstrom with active disease. With the smoldering Waldenstrom macroglobulinemia, we continue to monitor, particularly more closely in the first 5 years when the risk of progression is much higher. So as I indicated, that there are no randomized data to show that early intervention prolongs overall survival in this subset of patients. And our current approach is to just continue to wait and watch. And one of the main reasons is that we cannot afford to cause toxicities by early introduction of those treatments without any change in the natural history of the disease. For sure, we'll be able to make an asymptomatic patient symptomatic just by giving them treatment, because I don't know of any treatment that wouldn't cause toxicities. But obviously, based on the trajectory of the IgM levels, we can tailor the surveillance management that we currently recommend with more frequent testing and surveillance if the IgM level is continuing to increase, or we start to see low hemoglobin, or patients become gradually symptomatic. But it is actually international registries that would help us collaborate and inform us more in terms of how these patients truly progress and how often they should be surveilled. What is also important to note is that there are 2 important mutations that are present in patients with Waldenstrom macroglobulinemia. The more important one is the MYD88 mutation, which is present in almost 90% of patients, as we just heard earlier this morning. And this mutation actually leads to proliferation and survival, and is present in every Waldenstrom cells, not the normal cells of the patients, but in the Waldenstrom cells, and leads to increased growth. But in about 40% of patients with Waldenstrom, there's another mutation called CXCR4 mutation that is actually there are a number of types of CXCR4 mutations, and that leads to increased cell resistance to many therapies. And that is becoming more of a problem in terms of primarily management of patients with BTK inhibitors, or a class of drugs that I'll shortly discuss. But in terms of the number of chemotherapeutic agents that have been tested over the past four decades, we can see that a lot of progress has been made in the field. And this is what has led to improvement in survival of patients. We feel back in around 2000, when rituximab was being tested, and in 2005 when we started to see first impact of rituximab through clinical trials in Waldenstrom macroglobulinemia. And 2 years later, just addition of a steroid and an old drug called cyclophosphamide, leading to actually this Greek regimen or the Demopolis regimen of DRC as being one of the most popular regimens that is still being used across the world. Also, more recently, over the past decade, bendamustine, which is another chemotherapy in combination with rituximab, an anti-CD20 antibody, that combination has been used very frequently, particularly in the United States and some other parts of the world, only because we are starting to see, with just fixed duration of therapy, prolonged disease control. Just 4 to 6 cycles of treatment, and you could kick the can down the road for several years. If the vast majority of patients do respond to that treatment. And the reason why we have adopted this regimen as one of the main regimens that we are using currently in the upfront or frontline setting is because in 2013, the results of a trial called the STILL NHL-1 study were presented. And the results also included patients with Waldenstrom, and there were only about 41 patients. This was a subset of the entire study population. There were patients with marginal zones, mantle cell lymphoma, small lymphocytic lymphomas, which are related malignancies, but not Waldenstrom. But the impact on patients with Waldenstrom was immense. And as you can see, the vast majority of patients responded to rituximab and bendamustine as compared to R-CHOP, which was considered a standard of care at that time, a 5-drug regimen. So this 2-drug regimen of BR was able to produce good responses in almost 95% of patients. While the responses were quite equivalent compared to R-CHOP, the progression of free survival of patients was much longer with bendamustine rituximab compared to R-CHOP. And while these data have not been updated, what we do know is that based on subsequent studies, including some retrospective studies at our institution and other institutions, we have found that this regimen works very, very nicely and in general is fairly well tolerated with manageable toxicity profile. More recently, Dr. Buski in Europe did an ECWM1 study where they compared DRC with 6 cycles of DRC with addition of a proteasome inhibitor plus DRC. Again, this was trying to improve upon what was considered the standard of care of DRC. And what they found was that even though the depth of response was somewhat better with the 4-drug regimen compared to the 3-drug regimen, indeed there was no improvement in the progression-free survival of patients, and the follow-up was short to comment on the overall survival. The 4-drug regimen definitely increased the risk of the degree of toxicity as well as the frequency of neuropathy that is one of the side effects of bortezomib. But as you can see here, with rituximab monotherapy or rituximab as single agent, the response rates were between 50 to 60%. That improved if we gave, instead of 4 doses, 8 doses, with almost 2/3 of patients responding. But that overall response rate increased to close to 90 to 95% with just the addition of bendamustine to rituximab. And we have thus far not been able to show any advantage of using other drugs over bendamustine rituximab. In one of the retrospective studies from our institution, we found that DRC was somewhat inferior, but this is a retrospective study and not a head-to-head full randomized controlled trial. And this bendamustine rituximab was also superior to bortezomib-based regimen of BDR, or bortezomib dexamethasone rituximab. So that is why we at Mayo have adopted this as one of our go-to regimens in the frontline setting. And you can see almost a 6-year progression-free, median progression-free survival following just 4 to 6 cycles of bendamustine rituximab. Our approach is to give 6 cycles based on some more data that came out more recently from some works of Dr. Desa suggesting that 6 cycles are actually better than 4 cycles, and that's what we have adopted. So Dr. Ranjana Advani actually first led a trial in B-cell malignancies, and Waldenstrom is one of the B-cell malignancies, looking at the role of ibrutinib. And what she found was that ibrutinib was quite effective in a number of B-cell malignancies, and of the 4 patients who were of Waldenstrom, all 4 patients responded. And that was a good signal that led to this pivotal trial by Dr. Steve Treon from Dana-Farber, who looked at 63 patients who were enrolled in a study of ibrutinib just once a day, 420 milligrams. And again, this was an oral drug, very convenient to use, and he found that the vast majority of patients responded. So overall response rate was quite comparable to that observed in patients who are given bendamustine rituximab. So now we have a choice. We could choose 4 to 6 cycles, specifically my preference is 6 cycles of bendamustine rituximab, versus ibrutinib once a day on a continuous basis. But remember, we haven't shown that ibrutinib is any better or bendamustine is any better than ibrutinib, because this study was a single-arm study without any comparator arm or control arm, so to speak. But the results were so compelling that the FDA approved, on the basis of just this trial alone, ibrutinib monotherapy for Waldenstrom macroglobulinemia back in 2015. And this study exclusively looked at patients who had previously received therapy. Having said that, when the FDA reviewed the data, they approved it also for patients in the frontline setting, although the data were not available by that time. Dr. Treon did conduct a separate study involving 30 patients in the treatment-naive setting, and the results were, again, spectacular, with all patients actually responding. The good thing was, specifically for that study, that all patients had MYD88 mutation, all 30 subjects. But the reason I say that is because MYD88 mutation is important for these drugs to act. If patients don't have the MYD88 mutation, those patients will not respond well to ibrutinib monotherapy. And that's something important to remember, because patients who are MYD88 wild type will needlessly be given an expensive drug without obviously deriving the benefit that is typically expected with this agent given on a continuous basis until intolerable toxicity or disease progression. So some of the practical considerations when we give ibrutinib, like I said, we check MYD88 mutation. This drug interacts with a number of other drugs, so anytime patients are on other drugs, newer drugs, you should check with your doctor, let the doctor know that you are on ibrutinib or a similar drug, and they should look for any drug-drug interaction. There are certain fruits, fish oil, etc., that can interact with ibrutinib and can increase the side effects. It's important, given its risk of given the risk of bleeding, to stop the drug 3 days prior to a minor surgery and 7 days prior to a major surgery. Some of the major toxicities include cardiovascular toxicities, irregular heartbeat, or risk of atrial fibrillation, which in more recent studies is shown to be up to 24% with ibrutinib, and risk of hypertension, which is seen in up to 1 out of every 4 patients with ibrutinib. So important to remember that when you go to the doctor's office, if you're on ibrutinib or another BTK inhibitor, to ask for your blood pressure readings, because it's important to manage these side effects, because we want the patients to be on a drug that is working for them for as long as possible. And we want to avoid the side effects or minimize those toxicities by carefully managing their symptoms. So one of the keys for us as physicians is to ensure that all these aspects of patient care are looked into very closely in order to give the patients optimal care, because these things would allow the patients to be on the medication for a longer period of time till the new best thing comes up in the market. So the more effective we are at kicking that can down the road, the greater the likelihood of patient having another very good option by the time their current treatment fails, because the progress that is currently being witnessed in the field is simply mind-blowing, given the number of new agents. And speaking of new agents, zanubrutinib is a next-generation BTK inhibitor, and the makers of this drug they decided to, in a very bold move, compare their drug to ibrutinib alone in order to knock that competitor off. And what they found was that the drug was equally, if not more effective than ibrutinib. But what they also found was that their drug was better tolerated. And that is why zanubrutinib got approved. It isn't, in my mind, just another Me Too drug in terms of another BTK inhibitor, because the side effect profile is better. And the reason I say that is because the rates of atrial fibrillation, the rates of hypertension, the rates of hemorrhage, rates of myalgias or muscle aches, or rates of diarrhea, all these are lower with zanubrutinib compared to ibrutinib. However, zanubrutinib can cause more neutropenia or suppression of a type of white blood cells that helps us fight infections. So it's important to measure these counts periodically and make sure that they are within a safe range and that we don't have to stop treatment. But over time, what has also been found in more recent study results, is that zanubrutinib induces a deeper rate of remission or higher rates of very good partial remission, which is seen in almost 1 out of every 3 patients that are given zanubrutinib compared to 1 out of 5 patients who are given ibrutinib. And here's a list of BTK inhibitors that we have the data from. I don't have 2 drugs here, and I'll shortly discuss about those as well. But as you can see, a number of trials have been conducted with ibrutinib alone, ibrutinib in combination with rituximab, acalabrutinib, zanubrutinib, and also some newer drugs such as tirabrutinib, which is now approved for Waldenström macroglobulinemia in Japan, and also ibrutinib in combination with some newer drugs, including venetoclax, which is a BCL2 inhibitor. On your right, you can see some graphs that I have taken from a trial called Innovate trial. And this trial compared rituximab to ibrutinib plus rituximab. Excuse me. What you can see here is that ibrutinib plus rituximab is better than rituximab alone. But these two curves in red are actually showing the treatment-naive population, that means the newly diagnosed, as well as the previously treated patient population. And rituximab in previously treated patient population is not good at all. Rituximab monotherapy in treatment-naive population isn't necessarily considered a good control anymore. But importantly, what you can see here is that the graphs for previously untreated as well as relapsed refractory patient population are intertwined. The point I'm trying to make here is that if you get ibrutinib after bendamustine rituximab, your likelihood of responding and achieving a durable remission is no lower than if you get it in the frontline setting. So you are not losing out on anything by relegating BTK inhibitors to the next line as the next line therapy. And that's why my preference is to give a short duration of therapy with bendamustine rituximab first, unless and until we get some data showing that zanubrutinib or some of the newer therapies such as pirtobrutinib are better in terms of the durability of response compared to bendamustine rituximab. So the bar that bendamustine rituximab has set is exceedingly high for some of these competitors to overcome. And importantly, we talked a little bit about this. The role of CXCR4 mutation is important. What we have found with bendamustine rituximab is that it works just as good in patients with or without MYD88 mutation. But patients who have coexisting CXCR4 mutation along with MYD88 mutation may not do as well with bendamustine rituximab either. And that's something that's some new data that is being generated out of a collaborative study. Also, as I touched upon earlier, patients who have MYD88 wild-type genotype don't do well at all with ibrutinib, whether in the frontline or in the relapsed refractory setting, and it's best to avoid this agent. While there is some data to suggest that the addition of rituximab may overcome this issue of inefficacy in patients with wild-type, MYD88 wild-type genotype, what we also know from this study is the Innovate study, which has included rituximab in combination with ibrutinib, that the way the investigators tested the MYD88 mutation was not a very sensitive way, and more sensitive methods could perhaps have detected that mutation in many more patients, and that's why you are seeing some degree of equivalence between the MYD88 wild-type population as well as the MYD88 mutated population in terms of the response and the overall outcomes, because some of those patients have been miscategorized as MYD88, likely miscategorized as MYD88 wild-type. What has also been found in the ASPEN study that compared ibrutinib with zanubrutinib is that, that patients who have CXCR4 mutation are doing better if they're given zanubrutinib compared to ibrutinib. And over time, we are beginning to see even the progression-free survival curves sort of diverging here, indicating again that it's important to give a good drug early on, because that can change the overall disease course. Some of the side effects we talked about, risk of bleeding, risk of diarrhea, et cetera, is all related to off-target impact of these BTK inhibitors. And some of the newer drugs, such as pirtobrutinib, may be able to act on that same enzyme, the BTK enzyme, at a different site, and may be able to overcome the resistance that is seen in patients who are given continuous ibrutinib or zanubrutinib, just because they act at a different site, which does not get altered with continuous BTK inhibition. I don't want you to forget about autologous stem cell transplant. While it's becoming more and more rare in our approach to patients with Waldenstrom, but this is something that should be kept in our back pockets, especially if patients have not been able to respond well to bendamustine rituximab, as well as BTK inhibition. And sometimes we prefer to use some other oral agents that are now available, such as venetoclax, although that is not approved, as well as proteasome inhibitors, before we undertake something that is that could potentially be more toxic. So autologous stem cell transplant is one such approach, where we give very heavy-duty chemotherapy before transplant, and then given the collateral damage to the normal cells, we infuse patients' stem cells that are collected prior to the heavy-duty conditioning therapy. What we have also recently found is that patients who are given bendamustine rituximab or ibrutinib, they do just as well, and in this, I would say, retrospective comparison. So it doesn't matter if you have received ibrutinib or a similar BTK inhibitor and you're responding well, you don't need to change to bendamustine rituximab. If you haven't started treatment based on your preference of getting oral therapy continuously until intolerable side effects, or getting a finite duration therapy, you can choose. So our options are improving, and that is what is leading to better outcomes. Also, as I indicated earlier, it is important to dose reduce ibrutinib, because this is a marathon that, more like a marathon than a sprint. It's important for patients to get their drug, even if it is at a lower dose, as long as they are tolerating it, as long as the quality of life is not substantially compromised. And what Dr. Serosiak from Dana-Farber showed in a patient cohort of more than 350 patients, that almost 1 out of 4 patients required at least 1 dose reduction because of ibrutinib intolerance. But importantly, among those patients, almost 2/3 also, or I should say 1/3 also required a second dose reduction. But importantly, the hematologic response was maintained in the vast majority of those patients who required dose reduction. And in 1 out of 5 patients, the response even improved with dose reduction, because there weren't as many frequent disruptions. And so in the long run, that approach is preferred, as opposed to giving the full dose, but the patient's not being able to tolerate it and then having to stop it frequently. Also, we now have the option of switching over from ibrutinib to zanubrutinib in case patients are not able to tolerate ibrutinib because of its side effect profile. And what has been found in one of the studies is that in 70% of patients who were on acalabrutinib or ibrutinib, grade 3 toxicities did not recur with zanubrutinib. And in fact, those responses were maintained in more than 9 out of 10 patients and even improved in 2/3 of patients. We talked about venetoclax in relapsed refractory Waldenstrom. And what has been found is that venetoclax is an oral drug which is generally fairly well tolerated. We now give it as a ramp up for the first week, and then after that, we give the full dose of 800 milligrams a day. And a study has, even though it's a small study, has shown that the vast majority of patients respond. Although the responses are deep in only 1 out of 5 patients, in general, it is a well-tolerated regimen with some cytopenias, constipation, diarrhea being the major side effect, as well as infections being the major side effect. The drug works both in patients who have been previously exposed to BTK inhibitors, as well as patients who have CXCR4 mutation. But what is important to note is that this specific study that looked at venetoclax monotherapy looked at only 2 years worth of therapy. And what you can see here is when in this graph, at 2-year mark, when the patient stopped, a lot of these patients started to progress pretty rapidly within the next year or so. Again, indicating that if we are to use venetoclax monotherapy, it's likely going to be given until progression or intolerable toxicity. While venetoclax can be used for a shorter duration in other B-cell malignancies, it has to be given on a continuous basis for Waldenstrom for it to be effective and for it to achieve what we call durable remissions. So this is how we, in general, approach patients with Waldenstrom macroglobulinemia at Mayo Clinic. If they have IgM-MGUS or smoldering Waldenstrom macroglobulinemia, it's important to observe them. If they have IgM-related neuropathy or hemolytic anemia or cryoglobulinemia, we just give rituximab 1 cycle. And patients with symptomatic cold agglutinin disease can also get bendamustine rituximab or another drug which is now approved, sutimlimab, if patients continue to have symptomatic cold agglutinemia. But importantly, for patients with Waldenstrom macroglobulinemia who have symptoms and don't have hyperviscosity symptoms, we go with bendamustine rituximab for 6 cycles or zanubrutinib. But if they do have hyperviscosity symptoms as presenting symptoms, then we want to take them to plasmapheresis first, or avoid rituximab for the first couple of cycles because surprisingly, rituximab causes what we call IgM flare and can paradoxically increase IgM for first few cycles. And so it's important to avoid if there is coexisting hyperviscosity syndrome, or if the IgM levels, baseline IgM levels are very high to begin with. In first relapse, if patients have not previously received bendamustine rituximab, that is our approach. If they have received bendamustine rituximab, then we prefer zanubrutinib. In second relapse, our options have expanded even further. We have venetoclax, we have pirtobrutinib, which is a non-covalent BTK inhibitor, which acts, like I said, at a different site, as well as based on some data presented at American Society of Hematology meeting last year, the response rates are fairly high, 2 out of 3 patients responding, even if they were previously exposed to zanubrutinib or ibrutinib. So we have another BTK inhibitor. So if we get, let's say, 5 years from zanubrutinib and then go on to pirtobrutinib, you could still get, based on the study results, another 2 years, 18 months to 2 years, so 7 to 8 years just on BTK inhibition alone. Then we have bortezomib-based regimens and also another proteasome inhibitor called ixazomib that has shown quite a bit of activity. And lastly, as I mentioned before, we should not forget the role of autologous stem cell transplant. So as I said before, our options are expanding. I haven't mentioned a few which are currently being evaluated, including the role of CAR T-cell therapy, the role of bispecific antibodies, the role of now other non-covalent BTK inhibitors such as nemtabrutinib, role of CXCR4 inhibitors such as ulocuplimab and mavorixafor, role of antibody drug conjugate called loncastuximab, which targets CD19 as opposed to CD20, role of other BCL2 inhibitors such as BGB11417, which is currently being evaluated as well, role of mTOR inhibitors, which have existed for a long time. Again, something to keep in our back pockets and for patients who are not responding to other approved therapies, but given their side effect profile, are not preferred as the first salvage or second salvage regimens, and role of MALT inhibitors, role of IRAK4 inhibitors, role of BTK degraders. The field is just exploding. And within the next 5 to 6 years, we will have data with some of these very, very important and promising drugs. And with that, I would end my talk and open it for questions. Thank you for your time.
Please step up to the microphone then if you have a question.
Did I test it out? No. Thank you for being here. I appreciate it. So I have wild type, supposedly. What are the drugs that are on the horizon for that? And then do you think that zanubrutinib is effective? I think there's been some studies that show it slightly is, but that's pretty much. So wild type people and drugs and zanubrutinib.
Yeah, so thank you for bringing this up, and I apologize I did not elaborate on that specific portion of the ASPEN study. So the ASPEN study actually looked at zanubrutinib versus ibrutinib, and it had two cohorts. Cohort 2 that enrolled 28 patients was exclusively for patients with MYD88 wild type signature. And that was a single arm cohort. Interestingly, among those 28 patients, a third of patients, we saw response rates in 31% that were very, very deep, very good partial remission. So unlike ibrutinib, which is known to be ineffective, zanubrutinib has some degree of efficacy. We don't have much data with pirtobrutinib yet, but the Bruin study, which actually enrolled patients with Waldenstrom who received pirtobrutinib in the relapse refractory setting, enrolled patients regardless of their MYD88 mutation status. Now, with venetoclax, we have noted that in general, BCL2, the protein that venetoclax targets, is overexpressed only in patients who have coexisting MYD88 mutations. So it is unlikely to be as effective, but the best approach is chemoimmunotherapy in my mind. I haven't talked about purine analogs, which obviously, given their toxicity, are not usually preferred in the earlier lines of therapy, but purine analogs such as fludarabine, as well as now hopefully CAR T therapies and other bispecific that are targeting CD19 and CD20, which are expressed in MYD88 wild-type population. Hopefully, we will start seeing more promising data, particularly with regard to that specific population.
I have heard that if your first therapy was effective, you should consider repeating it. And in my case, 7 years now since my first therapy, which was chemotherapy, it was DRC. So what is the downside of repeating chemotherapy as opposed to moving to a BTK inhibitor? That's one question. The other question I have is, what is holding up approval of a lot of these drugs, like venetoclax? And right now there's only ibrutinib, and leaving out the chemotherapies, only ibrutinib and zanubrutinib, and there's pirtobrutinib and venetoclax, and I haven't heard any effort to make them approved for Waldenstrom.
Sure. So thank you for those questions. So specifically with regard to your first question about repeating therapy, that is certainly a very valid option. Specifically in your case, somebody who has experienced prolonged duration of response. 7 years with DRC is phenomenal. Typically, we see 3 to 4 years. If patients have achieved 3 to 4 years of remission and have tolerated therapy very well previously, there is no reason not to repeat. But the options are expanding. So at that point, if you've received with 6 cycles alone such good remission, you could certainly go ahead and get that again if you need at some point in future. But at least a duration of response of 3 to 4 years is required for you to be a candidate for retreatment with the same regimen.
Is there a danger of progression if you repeat chemotherapy?
Is there a danger of repeat? Yes, there's definitely. Many of these treatments do cause damage to the DNA. So there is risk of what we call second different type of cancer, called second primary malignancies, including MDS or leukemias. But those risks are small. They are not substantial. And so, yes, there is a risk, but you have to weigh the risks and benefits. And specifically with regard to your second question, while many of these regimens, other agents are effective, it also depends on the trial that has shown their efficacy. Some of these trials are early stage trials, and the drug company also needs to have these what we call registration trial and submit their data to the FDA for the regimen to be approved. So what I'm trying to say is that it's dependent on a lot of things, not just the efficacy. Regardless, in the US, because the drug is available, there are many physicians who are using it off-label as long as the insurance covers it.
Yes, one of the things that I have wondered about, and hopefully you can answer for me, about 1 in 5 people on BTK inhibitors have withdrawal when they go off of it for any number of days, and some of us have severe withdrawal issues. Even with the prednisone, it doesn't seem to help. So I'm wondering if you can tell me why 1 in 5 of us have those withdrawal symptoms, and is there any better way to combat it than with prednisone?
Great question, and I'm sorry I did not address that in the interest of time. What withdrawal symptoms means is in 1 in 5 actually experiencing it means if a BTK inhibitor is abruptly discontinued for whatever reason, maybe prior to a surgery, or if patients are not tolerating it well, patients would start experiencing symptoms like severe fatigue, fever, joint pains, etc. And that occurs because this BTK inhibitor is trying to suppress cytokine release. And suddenly, based on the pathway, there's this JAK-STAT pathway activation. And suddenly you sort of take your foot off the pedal, and it starts off the brake. And it starts just going at a very rapid speed. So what happens is these cytokines start getting released very, very in very high amounts, and that leads to this. Reinitiation of therapy is the best approach as quickly as possible. Prednisone at times has helped, but not in all patients. Then you start doing other symptomatic management strategies, such as using Tylenol for fever, but these are all like patchwork and not necessarily dealing with the predominant issue, which is the cytokine release. And in fact, about a third of patients on ibrutinib can experience, in conjunction with this withdrawal, IgM rebound phenomenon, where suddenly the IgM goes up, and it is then considered as false progression. What happens is if you restart ibrutinib, the vast majority of them would actually respond again. And unfortunately, we don't have much data on how to manage, but patients who have achieved very good remission are actually surprisingly more likely to get these withdrawal symptoms as opposed to the ones who have partially who have partial remission.
So I'm 6 years post-stem cell transplant for amyloidosis. And my question is how do you follow amyloidosis? How do I know if new amyloid is being laid down or this is legacy amyloid from prior to my stem cell transplant? How do you quantify it?
So very good question. So like I mentioned, about 7 to 8% of patients with Waldenstrom macroglobulinemia can have coexisting AL amyloidosis. And what happens is that this IgM, as well as the light chains, can get deposited in different organs. So the way we monitor patients with AL or ALH amyloidosis is by looking at their organ function. So checking their cardiac biomarkers, such as troponin, NT-proBNP, checking their 2D echocardiogram once a year, checking the urine protein, measuring it, 24-hour urine protein to see if there's any kidney involvement. Typically, and obviously assessing the symptoms such as edema, shortness of breath, easy bruising, diarrhea, etc. And so along with obviously the IgM levels. So we monitor the organ system as well as the monoclonal protein studies.
This will be the last question. I'm sorry.
Thanks, Don. Dr. Kapoor, I actually have a couple questions from our virtual audience, so if I try and make them short here.
Sure.
But does Mayo hesitate to do repeat treatments with bendamustine Rituxan because of risk of bone marrow damage? That's one. And the other one is there any noticeable direct toxic effect of ibrutinib on the kidneys?
So with regard to the first question, no, we do not hesitate as long as there is increased duration of remission, or at least four years or so, preferably 5. But there is definite increased risk of toxicity, specifically cumulative toxicity and DNA damaging toxicity too. And I'm sorry, the ill effects of ibrutinib, I'm not aware of ill effects of ibrutinib specifically on the kidneys. We can use it even in patients with renal failure.